Thank you for joining us for another edition of Ask the Mayo Expert. My name is Gayatri Acharya. I'm a cardiology fellow here at Mayo Clinic. Today we're talking about statins and if the benefits outweigh the side effects. We'll be taking your questions throughout the broadcast, so make sure to post your questions in the comments section below. Joining us to talk about this topic is Dr. Stephen Kopecky, a preventive cardiologist at Mayo Clinic. Dr. Kopecky, thanks for joining us today.
Thanks for having me, Guy.
Absolutely. So let's start at the basics. What is cholesterol and does the body need it?
Yeah. Well, every cell in our body has to have cholesterol in it. As mammals, that's just the way we live. And so we have to have a way to get cholesterol around the body for our cells to use it for things they make like cell walls, and also to make things like estrogen, testosterone, cortisol, progesterone. All our hormones need it. And so for that, we've had a thing called low-density lipoprotein, or LDL, that takes a fat-based molecule like cholesterol and puts it in a water-based system like blood, because anybody that's ever done cooking knows that fat and water doesn't mix very well, and it would mess up our bloodstream.
So we talk about LDL, but when patients come to us, they ask us good versus bad. Can you clear that up a little bit for us?
Yes, the LDL I mentioned, the low density, we want to be low because it's bad. So the high-density lipoprotein is the one that actually does the opposite. Instead of taking cholesterol out to the bloodstream, to the walls of the arteries and such, it actually removes it and brings it back. So we want the high-density, or HDL, to be high.
So how does a patient know whether they need to lower their cholesterol, raise their good cholesterol? How do we make sense of that?
Yeah, that it really is somewhat a numbers game, in that you do have to have numbers checked, because you can't tell what your cholesterol is just by looking at your skin or looking at a drop of blood. You really have to have it checked, and that means going to your caregiver's office, your primary caregiver, whatever. And really, when do you do that? Well, if there's a history in your family of early heart disease, early heart attacks, early strokes, you've known your aunt had high cholesterol, then that should be checked sooner rather than later.
Can the good cholesterol be too high? Can the bad cholesterol be too low? How do we sort out what range these numbers should fall in?
Yeah, those are really great questions. The good cholesterol, and the bad cholesterol. Well, the bad cholesterol really just does one thing. It's just taking the cholesterol out to the peripheral tissues in our body. So it's really needed for a purpose, and we need about 25 or 30. That's in our milligrams per deciliter, what we use here in this country. We need about 25 to 30, so all our tissues get enough and our hormones can be made and things like that. The HDL is a little different in that it doesn't just do one thing, it does multiple things. Not only does it do reverse cholesterol transport, which is cleaning out the arteries, but also it helps with platelet function, which are cells that clot. It helps with endothelial function, which is the lining of our arteries. It actually helps with viral and some anti-tumor properties. And so we need to have some of that, obviously. However, all of it doesn't do the reverse cholesterol transport. So if you have a really low HDL, that's bad. But if you have a really high one that's congenital, you're born with it, it may not be the one that cleans out your arteries. So I've told many women in my career, your HDL is high, don't worry, you're not going to have a heart attack. They've gone out of their way later in my career to find me and say, remember 20 years ago you told me I wasn't going to have a heart attack? Well, I just had one, And it's because recent data has shown that it's not always the good stuff that's high.
So when we talk about lowering cholesterol for overall cardiovascular health, that comes hand in hand with the discussion about statins. So where did we get statins and who should be on a statin?
Yeah, statins are, the first ones came out in this country in 1987, actually came from the penicillium mold that penicillin came from. The statins help lower cholesterol by working on the liver. They are really, game changers. They really are great if you have heart disease, if you have narrowing of the arteries to the heart and your cholesterol is high. If you don't have heart disease, then it's maybe a little bit different, because you can work and you should work on your lifestyle regardless. The foods you eat, the activity you do, the stress you try to avoid, the way you sleep, all those are important. But it's very important if you have heart disease that you ought to really consider being on a cholesterol agent like a statin.
So thinking about those points, do statins save lives?
Yeah. If you have heart disease, there's no doubt that statins save lives. In fact, you read a lot on the internet that statins are not good and it's a myth or a hoax. the highest selling drug ever in the history of the world was a statin. And these statins are the most studied drugs in terms of, numbers of hundreds of thousands of patients in randomized clinical controlled trials, more than any other drug that's ever come out on the market. So we do know they save lives.
And patients will often ask me, well, why do I need to be on this very high dosage of this particular medication? Can I start with something else? Can I start with a lower dose? How do we make sense, or how do we even explain to folks what dose a person should start with? Does it depend on the type of statin we're taking? Can you explain that a little more?
The type of the statin and the situation. Patients that have heart attacks or what we call acute coronary syndromes, you have pain that makes you go to the hospital and you get a stent or something. Those patients we start on usually like a atorvastatin, 80 milligrams, the highest dose. And that's been shown to start a lower dose, the patient does worse, even just a month later. In the first month, they have better outcomes with a higher dose. So we do have evidence that it helps them. Now, the flip side of that is their side effects. People can get muscle aches. And those muscle aches can occur anytime, the first few doses or 10 years later. And we have to tell patients, hey, this can happen. And if it happens, let us know. And the muscle ache is usually a bilateral pelvic girdle or shoulder girdle, the upper arms, upper thighs, both sides, not just one. It's not just your right thumb or your left toe or something. But and it usually manifests with a stiffness, a soreness. You kind of think, gee, what did I do last weekend? Did I play a, pickup game of basketball with a bunch of 18-year-olds or something, So it can creep up on you. But we tell them to call us and let us know, and we can work something out.
Now, is that what we should think of when we think of statin intolerance? Is that what we should explain to our patients? Is there anything else that should be included in that? Or what is encompassed in the idea of statin intolerance?
Yeah, good questions. 90% of the intolerance symptoms are muscle aches, but also diabetes can occur. And diabetes will occur in people usually that are prone to have diabetes. They're going to get it anyway, but they get it about 3 months earlier on a statin. And those people are the ones that may have a big abdominal girth, the metabolic syndrome we call it. They may have an elevated fasting blood sugar. They may have an elevated hemoglobin A1C, which is how we monitor diabetics. And so that can occur. But for every one patient that becomes diabetic, there are 5 heart attacks prevented. So that's important. The other big thing that everybody's worried about, of course, is dementia or memory problems. And that's been studied extensively, and it really has not shown that memory problems occur with this. Now, we all have anecdotal patients that can't remember something. They get off their statin, they remember it. Well, that happens to me too, and even if you're not taking a statin, that can happen. So we have to balance out the risks and the benefits for these things.
If a patient comes to me and tells me, well, my sibling had statin intolerance, I'm a little scared to start it. Does statin intolerance, do these inability to take a medication because you may develop side effects, does that run in families? Yeah,
it sure can. And there are some genetic issues with that. We used to think that the SLC01B1 SNP or genetic trait was a predictor of simvastatin intolerance, but we really haven't seen that. It depends on kind of the population you're in. So I do ask patients frequently, ask around at the next Thanksgiving, what can people take and what can't they take? Because it does seem to run in families.
Mm-hmm. And do we tend to see the statin intolerance, the muscle cramps, at the initial dosing of the medication within the first few days or weeks, or can it develop in time? How should we counsel our patients on that?
That I'll tell patients that, very rarely it could occur after the first couple of doses, but usually the first few weeks. It can also occur after you've been on it for years and you have some stress like a bad flu or a surgery or something like that. And usually it goes away after being off it within about a month.
And a question from our audience, do I need to stop taking the statin? Do I need to do that at a taper, or can that just be done in an abrupt fashion?
Yeah, good question. Just cold turkey it, go off it. And we suggest to patients to come off it for a month. And don't go on anything else for that month, because sometimes you'll go off one and start the next one, and the next one perpetuates the symptoms of the first one. And the same can be true with ezetimibe, which is a drug that blocks cholesterol absorption in the gut that works well with the statins, and many people are on it, but it can also be kind of caught up in those side effects.
So if one were interested in ruling out statin intolerance, muscle cramps, perhaps stop both at the same time?
Yeah, at least stop the statin first and then let the symptoms go away, and if they don't, stop the ezetimibe too.
Now, a complementary thing to taking medications is always your lifestyle, and we briefly touched on this before. How can we complement the use of statins with diet? What should people avoid? What should they be encouraged to do?
Yeah. And when every statin that's come out, the FDA in this country has said the statin is in addition to a good diet. And so the good diet that we encourage here is the Mediterranean diet. We may have a graphic of that, of a Mediterranean pyramid we could show that has more fruits and vegetables, more legumes, anything that breaks in half like a pinto bean is a legume, more fish, more white meat, poultry, more olive oil, and a few nuts a day, less red meat, less dairy, less cheese, things like that. That has been shown to be quite altering in terms of lowering your risk of dying and of not just heart disease, but lowering your risk of dementia, lowering your risk of multiple cancers, lowering your risk of arthritis. It's an anti-inflammatory diet. So patients come every day and say, okay, my cholesterol is a little high, but let me try it my way. And we say, great, I think that's wonderful. So we have actually a list of foods they can eat, specific foods or supplements, that we may have something we can show of things called sterols or stanols, that you can find them in things like soybeans, but you'd have to eat a couple of bushels a day. So we actually can buy it in supplements, have it in your gut when you're eating other things. It comes like as pills or on margarines or in juices. Also a soluble fiber like oat bran, oatmeal, good old regular oatmeal you buy at the store, and just mix it up and eat it. Make sure it's not a lot of butter and brown sugar and stuff. That will lower cholesterol. And then things like psyllium, which many people take for their gut, but that's a specific soluble viscous fiber that lowers cholesterol and blood sugar too. And so we say go on that for a month or two and see how things look. We've shown here in some studies that there's certain genetic traits that you have a much more pronounced response to that. So instead of a 10 or 12% reduction in cholesterol, you get a 30 or 40% reduction. But we just tell people just take the substance, eat this stuff, instead of doing the genetic testing to see what's going to help them.
That makes sense. I've heard of a few other supplements, in addition to the ones you've already mentioned, that patients will come to us and say, I'd really prefer this over the statin. Can you speak a little bit about those, and is there any evidence to support some of the alternative therapies to cholesterol?
Yeah, the one that's most commonly talked about is the red yeast rice. And there is a yeast that it grows on rice. And it actually is kind of a second cousin to lovastatin, the first statin approved in this country. And that can be very helpful. I actually tell patients don't take that, because if you want to take that, let's instead give you the cheaper, actually it's cheaper to take a generic lovastatin. And we know the dose, the stuff you buy over the counter, you don't know the dose, and you don't know what else is in it. Other things have been talked about, certain supplements, turmeric, Google, other things, they really haven't been shown to be that helpful. Polycosamine a few years ago was a big thing. It turned out to be a scam. But we, in general, encourage, the healthy eating and the substances that we know that will help lower your cholesterol.
Another complementary thing to both diet, medications, and just being attuned to your health is aerobic exercise. Is there any role for aerobic exercise in cardiovascular health?
Yeah, aerobics, that's what we used to do. A million years ago, we didn't get up in the cave in the morning and say, honey, I'm going to jog for an hour and get you a latte. We'd say, I'm going to leave the cave, try to find some food, not be killed. We would go out, we'd walk, and then we'd run real fast to chase a rabbit or something would chase us. And we'd do intervals. That actually helps raise your good cholesterol more than just regular exercise, and exercise is good too, and also lowers your triglycerides, another fat that we find in our blood. So aerobic exercise is very important, but it will not lower LDL cholesterol.
And another very popular question that I get from patients, and we see in the media, and this is actually a question from our audience, what about other supplements such as krill oil, fish oil with the high amounts of EPA and DHA? Yeah,
no, it's a great question, and two ways to answer that. One is EPA and DHA. Look on the side of the bottle, not just on the front, 1,000 milligrams, but the side, and try to get 1,000 milligrams of the EPA and DHA per pill. Secondly, don't get the krill, because you need about 8 of those krill tablets, and they say, well, get the fish oil where the fish get fish oil, they eat the krill, but it's just way expensive. And the third thing is, who needs fish oil? Well, people with high triglycerides, it's been shown to help. Triglycerides over 200, that helps. There's been data looking at just taking a pill a day. It really hasn't seemed to help people that much, so we really try to limit it to people that have high triglycerides.
And sometimes I even get asked, should I not take fish oil? Is there any patient who shouldn't be on fish oil?
Well, fish oil is pretty well tolerated. Sometimes you have a fleshy, kind of a fishy aftertaste, and the cats in the neighborhood will follow you around on your afternoon walks. But there's data in the derm literature that it helps wrinkles. There's data in some of the eye literature. It helps lacrimation or tears. They're looking at for Alzheimer's. And I think the best thing is to eat fish 3-4 times a week if you can. But if you can't, it may be worth taking some fish oil.
Absolutely. Now, one other question that seems to come up is, how do we use a coronary calcium scan? It seems to be a more popular scan for people to have, especially if you don't have frank coronary disease that you know about yet. You often start with that CT coronary calcium scan. Is there any role for that in making decisions about patients' statin use, cholesterol lowering?
Yes. That really the one randomized trial we had was a calcium score over 300. That's an absolute score. Those patients did better taking a statin down the road, years down the road, than ones that didn't. The new guidelines that came out for cholesterol about 3 or 4 months ago actually included coronary calcium scores and said anybody that has calcium, you ought to think about, calcium in their coronaries, think about a statin for them. And certainly if it's over 100, then they really think very hard about it.
And that seems to be most helpful in our patients where it's a little indeterminate. Would you say that's correct? And using it as something to really push for the use of that statin to lower risk. We have another question from the audience. If you have no other risk factors, what age would be too young to start a statin?
Well, we have a risk calculator that we use, and the calculator, it takes into account, what year you're born, your gender, your ethnicity, because certain ethnic groups have more heart disease than others. Do you smoke? Do you have high cholesterol, et cetera? And face it, if you live long enough in this country, you're likely to get heart disease. So usually in mid-60s is when we start to say men are at risk, and maybe early 70s women are at risk, even without any other disease. And that's when we start to think about it, if they have no risk factors. But that's the rare person.
Now, once you start a statin, is that a medication you need to be on for the rest of your life? And is there another question from our audience, is there any negative impact of being on a statin long term? Yeah.
We have studies out to 8 or 10 years, and we've got observational studies, 15, 20 years. We know there are side effects we've talked about earlier, but in general, if you need it, there's much more benefit to taking them than detriment. The problem with taking a pill every day, you've got to remember to do it, and we're not very good about that. And so I do encourage patients to do as best they can with taking the pill if they can do it and remember it. And if they have heart disease, meaning arteries narrowed in the heart, it really will benefit them.
So it's something that perhaps somebody should be on indefinitely if there's no other reason to stop it, and there's no. Now, what about the patients who have a positive impact from the use of the statin? Let's say they get their LDL 50% less than it was at the incident checkup. Is that somebody who should go off a statin?
Yeah, now oftentimes, I'll see a patient that's got a horrible diet, eating a lot of saturated animal fat, things like that we know will raise their cholesterol, and say, okay, let's get you on a statin, come back in a year, or a few months, a year, whatever, try to change your eating habits, and then we'll see how you do. They come back and they say, and we look at their numbers and they're much improved. And I say, great, how's it going with your eating? So, well, doc, I've been so busy, got this new job, and I'm traveling a lot, and I can't, I say, okay, then the benefit is probably the statin. Let's not change it. But if they come back and say, listen, I am really changed, I'm trying my hardest, and I'm doing this, I say, great, let's get off it and see how much of it is due to your lifestyle rather than the pill.
Now, another question from our audience, and we touched on this briefly. Is there a genetic biomarker that indicates whether a statin will cause muscular pain for a patient?
Yeah, we did talk about that SLCO1B1, the gene that we used to check a lot for simvastatin when it was a brand name and very expensive. We actually did a study here and showed that it really didn't predict, so it's population dependent. There is no single genetic study that will tell you, because statin intolerance is so multifactorial. It's not just one gene that causes it. Kind of like cholesterol is multifactorial.
Right. So what would you recommend if you had to give somebody if you had a minute to kind of pitch statins or pitch cardiovascular health, what would be your recommendations for who should be on a statin and why?
If you have known coronary disease, you really should be on a statin. And also always caution them, it doesn't have to be the highest, super highest dose. Just something is better than nothing if you have muscle side effects. The second, if you have a family history of early heart disease, you ought to get your lipids, cholesterol checked. You may need something. And if you have other risk factors, if you're a smoker and you're diabetic, then all these things add up and change the thing you can change, which could be taking the statin as you're working on stopping smoking and getting your diabetes under better control.
Absolutely. We have a great question from the audience. I found out I have an Lp(a) hereditary cholesterol and would like to know your opinion on what statin and other interventions are recommended. So how do we address Lp(a) in patients, and how does it impact their...
Yes. Lp(a) in the general population is like 20% of people. In the coronary care unit, especially for your young, it's maybe 40 or 50% of the patients there. So it's part of the LDL family in that it has a receptor on it that causes atherosclerosis or damage to your arteries. So we start to suspect it if you come in and you're young and you have a heart disease, or your brother just had a heart attack, and he's 3 years older at age 43 or something. Or if you've had heart disease and we've done all we can for you to prevent further events, then they keeps recurring, so we think about it. The problem is we don't have a medicine for it. There's some being studied, but we don't have a pill that fixes it right now. And I tell patients like blue eyes. If you have a high Lp(a), it's like blue eyes. I don't need to keep rechecking it or send you back to the eye doctor for them to tell me you have blue eyes. It's going to be there. It's a genetic thing. So hopefully some of these newer medicines in a few years will help. But if you have it, you should consider being on a statin, and you should really consider changing your lifestyle as healthy as you can.
Absolutely. What other common questions do you get from patients about statins that we haven't addressed? Anything that's sort of...
Yeah, a lot of times they say, well, do I have to take this every day? And we'll say, you don't have to take it every day. In fact, we want you to take what you can tolerate. And so I have many patients that take a statin once or twice a week. And we add to that ezetimibe, which blocks cholesterol absorption in your gut, and we can get some remarkable reductions in your cholesterol. And so sometimes the enemy of good is better, and we try to give them this high dose, in which case we just say, take what you can, and I always say, you're the boss, because I've talked to people many times, they've been on 6 or 8, 8 statins is all we have. And I say, okay, first off, I want you to try another one, but you're the boss. If you get the symptoms, you stop it and call me, and then we can let you wash out for a month and then restart a lower dose. And that, it can be quite remarkable how much it can help.
A frequent question I get is about supplementation with CoQ10, Coenzyme Q10. How do we make those decisions? Who's the right patient to receive the supplement? Is there anybody who really needs it?
Yeah. Well, anybody that takes a statin, their CoQ10 level goes down in their blood and in their muscle cells. And Coenzyme Q10 is with the long name. It's actually involved with energy generation in your muscles. So people thought, this is the cause of statin intolerance, of muscle aches. But you look at it, and giving CoQ10, if we say, gosh, this is really going to help you, take this, it seems to help. But if we do a double blind, meaning I don't know and you don't know what you're on, randomized trial where we flip a coin, it doesn't help. Okay. And again, it's probably because it's such a multifactorial entity, the statin intolerance, that while some may help, and I tell patients to try it if they want to take it, take a couple hundred milligrams a couple of times a day, give it a month or two. If it helps, it'll help by then. If it not, then you can get off it. And it's a very well-tolerated product you can buy over the counter in stores.
Now, what do we do for the patient or the individual who goes off, washes out their statin, and they're still having muscular pain, or they're still having something which they attribute to statin intolerance? What's the next step there?
This is tough, very tough, because this is not, if you and I see a patient with a heart attack, we do blood tests and find the substance elevated. Or they have a narrow valve, we do a sound wave test and we can show the valve narrowed. We don't have a single test that tells us this patient has statin intolerance. So what do? Well, we have to believe them, number one. Number two, say get off of it for a month. Anything that was due to the statin will go away in that month. If it persists, it's probably not the statin because the statin's gone by then. There is a very rare, 1 in a few 100,000 people that'll get an antibody to a statin that also reacts on your muscle and gives you some muscle weakness, primarily not pain, but weakness. And that's really quite a rare entity, but it does happen, and we check for that if they have primarily weakness but not pain. But in general, we say, just try to get on something.
We have another question from the audience. I was told my HDL count is higher than normal, but is non-functioning, not proactive enough to offset the LDL levels. What does this mean?
Yes, think of the HDL as almost like the old game Pac-Man, going around the artery, cleaning it out. But not all the HDL does that. There's some HDL does other functions like we talked about a minute ago. So you can't assume that a high HDL will counterbalance the high LDL. So if you have a low HDL, you can raise it. You can raise it with physical activity, the aerobic activity you asked about a minute ago, and the interval activity, where you go hard for, say, 30 seconds or a minute. Swim one lap really hard and the next one come back slower. Or take 3 or 4 flights of stairs during the day, as quick as you can. That can really help raise your good cholesterol, and that raises the good one that actually cleans out the arteries.
Now, one thing we haven't touched as much on is triglycerides, and this becomes quite an issue, I feel, for our diabetic patients. Yes. How do we address triglycerides? Are statins the mainstay for that, and what's the plan of attack for? Yeah,
good question. The triglycerides do go up a lot with the people that have high blood sugars, like the diabetics. There are 3 things we try to get everybody to do that aren't prescription medicines, because statins don't work for triglycerides. One is be more active physically. There was a study I quote all the time to patients of men that were inactive. We got them active. Their triglycerides went from 235, which is high. We wanted like under 100, and in 4 days they went down to 104 with just physical activity. The second thing is what turns into triglycerides? Well, it's carbs, like processed carbs, processed foods. We eat too many processed foods, so be careful with the automatic foods that you sit down at the restaurant and they give you some white bread and you start eating it, and then pretty soon you realize the bread's all gone. Or the calories that you eat that are addictive, which are the processed foods, which are actually shown to be quite addictive. And the third thing we try to do is fish oil. We talked about fish oil a minute ago. Take 2 or 3 pills of 1,000 milligrams a couple of times a day, so you get 4 to 6 grams of fish oil, the EPA and DHA, per day, and that can lower triglycerides quite a bit. So it really ought to be all 3 of those things that you do.
And what's the role of alcohol consumption on triglycerides? I feel that that's something that's not public knowledge.
Yeah, it is not that well known, but alcohol is pretty much pure. It's pure carbs, and you have a couple of drinks at night. That's a lot of carbohydrates, and so we always ask people, do you eat a lot of the whites, the white bread, white potatoes, white pasta, white rice? Do you eat a lot of things like juices, because they have a lot of pure sugar in them? Or eating processed foods, and do you eat things, or you drink much alcohol? Because really, the Mediterranean diet we talked about earlier gives you 1 glass of wine, 5 ounces for a man, 3 ounces for a woman per day.
Thank you for joining us today for our discussion about statins and cholesterol. This discussion will be on Mayo Clinic's YouTube channel for future viewing. If we didn't get to your question today to answer it, we'll try to do so after the broadcast. Thank you and have a great day.